Good afternoon and thank you for joining us for our webinar. During the webinar today, you'll be able to add questions for our panelists via the drop-down box in your control panel. You can post questions at any time and we will have time for question and answer during the session at the end. Your mics and cameras will remain off for the session. This webinar is being recorded and it will be made available on the Eracy website and YouTube channel. Eracy hosts webinars to share information and promote discussion across a range of topics. We welcome the opportunity to highlight the research of others and centre the voices of those with lived experience through these webinars. We now seek to grow capability and knowledge across the sector. I would like to introduce Kieran Sampson from the Eracy Knowledge and Translation team, who will open this webinar.
Hello, everyone. Welcome. Thank you for joining us today. We live and work on lands whose sovereignty was never ceded and acknowledge the deep connection Aboriginal and Torres Strait Islander peoples have to country and community throughout Australia. We pay respect to elders, past, present, and those yet to be. Eracy supports the Uluru Statement from the Heart. We seek to see our children thrive. Children are central to the Uluru Statement, and through meaningful dialogue, change can be driven to build a better future. We are open to change. Responsive relationships built through dialogue and positive interactions are crucial to developing healthy brains and healthy lives. We acknowledge a history of displacement can have intergenerational effects, contributing to adverse experiences for children and families. Supporting and modelling respectful dialogue in the community will produce and promote connection and engagement to deliver improved outcomes for children and families. What fosters positive developmental outcomes for children and their families will foster positive outcomes for us all. Thank you for joining us for today's webinar, Handle with Care, Supporting Foster Parents Caring for Infants. Recent research undertaken as part of a study exploring the care of infants in foster care found, sadly, that children of infant age are the most likely to be placed in out-of-home care due to allegations and substantiations of abuse and neglect, including exposure to substances in utero and early life. Research undertaken by Western Sydney University to explore the experiences of carers in New South Wales, with a particular focus on the training and support carers receive in their role, found some surprising facts, like around 25% of carers indicated they had not had biological children of their own and therefore had no antenatal or postnatal experience, nor were they provided with training with qualified healthcare staff covering basic infant needs. And fewer than 35% of respondents reported receiving training related to attachment and developmental trauma. We're joined today by Dr. Stacy Blythe, who not only contributed to the research and report titled Carers' Perspectives Caring for Infants in Out-of-Home Care in New South Wales, but who also has her own personal experience as a foster carer for over 18 years. Stacy is an Associate Professor in the School of Nursing and Midwifery at the Western Sydney University and the Deputy Director of the Translational Research and Social Innovation Group at the Ingham Institute for Applied Medical Research. Stacy's research focuses on the health and well-being of children in out-of-home care and their families, both birth and foster families. And as a lecturer in infant mental health, she's particularly interested in infants who are prenatally exposed to harmful substances such as illicit drugs. Welcome, Stacy, and thank you for agreeing to speak about your research today.
Thank you, Karen, for that lovely introduction, and thank you everyone for attending today. And before we go any further, I just want to take a moment to, first of all, share my screens. And can everyone see that? Yep. And I'd like to take a moment to just, and acknowledge that this presentation was developed and is being presented of the Darug people of the Darug Nation, and I acknowledge their ancestors as being the traditional custodians of this land for thousands of years. And I also want to pay my respects to elders past, present, and emerging. Just a little bit of background. As Kieran said previously, infants are an inherently vulnerable population due to their complete reliance on adults. Infants and young children less than 4 years of age represent the highest proportion of admissions into out-of-home care in many Western countries, including Australia. In the Australian context, infants under 1 year of age are more likely than any other age child to be the subject of allegations and substantiations of child abuse and/or neglect, and thus more likely to require placement into out-of-home care. The majority of infants receiving out-of-home care services are placed into home-based care with foster or kinship carers who have been vetted and authorized by relevant governing bodies in each state and territory to provide day-to-day care. Carers are to be provided with ongoing training as part of their caregiver role. However, there is emerging evidence that carers may be lacking in skills related to infant care. We're going to talk about this today. Foster and kinship carers have a significant responsibility to ensure the health and well-being of infants in out-of-home care. However, whether or not these carers are receiving the specific training and support required to adequately care for infants, many who have increased caregiving needs, is mostly unknown. I'd like to tell you a little bit about my own journey in order to give context to what I'm going to share with you. I first became a mother in 1992, and I moved to Australia in 1994. I became a registered nurse in 2003 and became an authorized foster care in 2005 because I felt like I just had something more to give. I completed my honors degree in 2008 and completed my PhD in 2013. And my PhD explored the experiences of women providing long-term foster care in the Australian context. So throughout that journey, from 1992 to 2013, I became the proud mother of 8 children, 4 of whom came from my own body, and 4 who are a sibling group who came to me through the out-of-home care system. So now I'm a mother to 8 and a grandmother to 2. After my PhD, somewhere in 2014, 2015, I was approached by Karatani to develop training for foster carers related to infants who had experienced prenatal substance exposure. And it was that moment that I found my purpose. And this began my research journey. So over the next several years, I began to do more and more research related to infants in out-of-home care, and in particular, infants who have been substance exposed. This isn't all of the papers that I've done, but this just shows kind of how the journey goes along. We talked to nurses about caring for these infants in hospital. We talked to carers about feeding these infants. I wrote about the need for substance-exposed infants to not languish in hospital and to have an attachment figure. We reviewed models of care to see what worked and what didn't. And we conducted the research looking at infants being cared for in out-of-home care in New South Wales. I've written about the need to change the diagnosis so that there's an enduring diagnosis for these infants. And most recently, we've also conducted a survey and some interviews with carers who are providing care to infants who have experienced prenatal substance exposure. And I'll give you a sneak peek at what we found from that today. Over this time, I've also written several blogs, participated in radio interviews, television documentaries, with the most recent being Four Corners, where my eldest son in care was also interviewed, sharing some of his experiences. Unfortunately, despite all of this work and despite all of my efforts, things seem to be changing very, very slowly. What did we find when we talked to nurses about their experiences of caring for infants with NAS? Well, we found 3 main themes. The first being facilitating the attachment relationship. Attachment relationship, of course, being that bond between an infant and a primary caregiver, which is essential during infancy and toddlerhood and really throughout life, but really super important during infancy. And we found that there were some barriers to that, barriers to promoting this attachment. On the screen are those themes that we came up with. So one of the things that we found was that there's definitely a benefit for infants, that attachment is vital. The nurses understood that. But there were barriers to promoting attachment between the infant and their mother if the mothers were substance using. One of the things was these infants have symptoms that can make them very difficult to bond to, things like a high-pitched cry and scream, and sometimes being very stiff when they're going through withdrawals. Babies are very difficult to soothe. Another one of the things that we identified was that the biological parents have unique circumstances. Usually it's very rare if mom only has a substance use issue. There's usually many social and economic issues that impact on her ability to be able to be present in the hospital and bond with her infant. And then, of course, Child Protective Services. One of the things that we found is when Child Protective Services becomes involved, mothers often don't want to be at the bedside for fear of being scrutinized and stigmatized, or Child Protective Services may make the decision to restrict the mother's access, meaning that mom's not allowed to be there unless there's someone supervising. And this, of course, is not conducive to an infant developing attachment to a primary caregiver. And of course, what the nurses said and what we were most interested in is how they promote attachment for these infants in the absence of the mother. And essentially, as you can see, one of the quotes was, "I guess we just do what we can." The nurses don't have the ability to facilitate attachment for these infants if there isn't an attachment figure present. And then, of course, we went on and identified a number of difficulties that the nurses actually had in the hospital while they were trying to provide care to these infants. One of the major things that we found was the inability for the service system and the healthcare system to actually communicate effectively with one another. Nurses often didn't know what happened to the infants once they were discharged from hospital. The nurses identified that when they were discharged into out-of-home care, sometimes they were just picked up by a driver or a caseworker rather than the carer whose home they were going to. So the ability to give handover and say, this is what the infant's been doing, this is when the infant needs to feed next, wasn't clearly communicated. So there's a lot of work that's left to be done there. The other thing that happens is these infants are not routinely referred for child and family health nurse home visiting services, because usually those services are offered to the mother rather than the infant. So in the absence of the mother, the referral doesn't go through. And this is one of the things that I found most distressing when we were following up what was happening with these infants. After that research study, I worked with a couple of pediatricians from the United States to do a review of models of care that are currently in place in the hospital looking after infants who have been born prenatally substance exposed. And what I found, what we concluded was that there's a number of different treatments. There's pharmacological treatments, the use of medication to help withdrawal, and there's non-pharmacological treatments. But most of the non-pharmacological treatments that they use to help treat the symptoms of withdrawal don't actually have any rigorous evidence behind them. So for example, one of the things that we tend to do with these infants, because they tremor a lot, they shake during their withdrawal, is we swaddle them and we wrap them very tightly. And this is commonly used. Now there's lots of research saying that swaddling is good for infants, but there's no research that says swaddling is good for infants who are experiencing withdrawal. But nonetheless, this is what we are doing. Another example is the reduction of noxious stimuli and trying to keep the hospital unit as quiet as possible, which is really hard to do. There's lots of bells and whistles and people always coming and going in the hospital. But they try to do that in order to decrease the infant's arousal. Again, there's no research that demonstrates that this is actually effective. There's consistent evidence, though, that the interventions that are effective, like skin-to-skin contact and breastfeeding and rooming in with the mother, those are the three things that have been studied. And those are the three things that have been demonstrated as most useful for soothing the symptoms of withdrawal and shortening the length of hospital stay. But unfortunately, those particular interventions aren't possible if Child Protection Services have stepped in and removed the mother from the situation. So this increases the likelihood of infants who are placed into out-of-home care requiring more pharmacological treatment, experiencing longer lengths of hospitalization, and thereby developing poor attachment, as was demonstrated in the first study that we did. The conclusion of this particular article, when we looked at these models of care, we said models of care for NAS, or neonatal abstinence syndrome, which is the withdrawal syndrome they experience, that promote baby-centered, function-based, non-pharmacological care with the mother as the primary means of treatment may be more effective in reducing the length of treatment and the length of stay than those focused on specific medications, protocol standardization, or home-based pharmacotherapy. Given the evidence to date, care for opioid-exposed newborns should occur in the settings that maximize rooming in and trauma-informed support for families. Social ecological approaches to care should be incorporated to help optimize maternal-infant health outcomes and safe transitions to home. Further studies are needed to assess these models of care on maternal-infant attachment and long-term neurodevelopmental outcomes. And then the lovely last sentence that I insisted we include: research investigating scenarios where the infant has been separated from the mother, such as foster care, are also warranted, as care models used in these situations will likely differ. It's extremely interesting to me that we have not investigated more fully models of care to support infants who have been separated from mothers. Although the first point of call is to try and keep the infant with the mother, we know that a large percentage of infants who come into out-of-home care have experienced prenatal substance exposure and have been separated from their mothers in hospital. So even if trying to keep them together is our first goal, should we not have something in place to support them if that goal is not achieved? My argument would be absolutely we should. So after we looked at those models of care, we did another study, and we looked at infant feeding in foster and kinship care. And the way that we did this is we asked about things like formula feeding and breastfeeding, because we didn't want the carers to think that we were looking for something in particular. But what we really wanted to know was what was happening when they received these infants and how much information that they were getting. And what we found is that there was, in general, foster carers were really supportive of infants in out-of-home care being breastfed or receiving express breast milk from their mothers. But the vast majority also held concerns regarding the safety of breast milk for consumption. Although the study did not solicit information from foster carers regarding the infants placed with them had entered their, although the study did not solicit information from foster carers regarding why the infants had been placed into out-of-home care, their responses indicate that many were concerned about maternal substance use. In fact, it is in fact probable that many respondents would not have had information about whether the infants had been prenatally substance exposed, born substance dependent, or had experienced substance withdrawal, even if they were aware of maternal substance use. They may not have been aware of what substance mothers had been using. Poor communication between foster carers and social service professionals is a persistent problem repeatedly reported in the literature. There was a recent study of over 1,000 carers, and less than half reported receiving sufficient background information when the child was placed into their care. This lack of background information places foster carers in a situation where informed decision-making regarding the use of express breast milk is not possible. So in our study, the majority of foster carers seem to believe that the best action was to not provide infants in their care with breast milk from their mothers, just in case it was unsafe. Unfortunately, this means that some infants were denied access to safe breast milk. This was very concerning for us because we know, as do many of the foster carers, that breast milk is, well, nurses and midwives, and I'm a nurse, say breast is best because it has wonderful nutritional value for infants. It's specially designed for infants. It provides extra immunity, and there have been many studies that show the benefits for children long term, even if they're breastfed for a short amount of time. So it's very distressing to us that these infants were denied access. Had the carers received sufficient information and been given sufficient training, they would have been able to make better decisions about whether or not the infants were to receive express breast milk when a mother actually provided that opportunity for her infant. And imagine being that mother who's taking the time to express and send that milk so that the infant can have it, only to find out later, after going to all of that work, that the milk had been discarded. So this led to the next study that we did, which was looking at carers of infants in New South Wales. So I really wanted to understand what was happening. Were other carers experiencing things like I had were the anecdotes that I was being told by my fellow carers actually what was happening? Who was caring for them? What were they experiencing? Did they get support? Did they have what they need to do their role? So this particular study was co-funded by my university and Adopt Change. And this is what we found. So we had a total of 232 respondents. And these respondents had to have taken care of an infant in the last 5 years in order to answer the questions. So this is the way that we made sure that we had a contemporary perspective of what's happening. So we had representation from every state and territory, overwhelmingly, mostly New South Wales. Marital status of participants, the ratio of foster is very similar to what you will find in the national statistics as it relates to foster and kinship carers. We had a predominance of foster carers, which is really interesting because currently there are more kinship carers than there are foster carers in the national sample. And very interestingly, 33% of the 232 carers who participated in the survey had no biological children of their own. So this is going back to what Kieran said before. These carers had never attended antenatal classes or had the benefit of a midwife postnatally showing them how to bathe an infant. And for those of you who have ever bathed an infant before, the first time you do it, it's very scary because they can be slippery little suckers once you get them all soaked up. So to be eligible, they needed to have received care of an infant in the last 5 years. And this was to enable that contemporary perspective. We did also collect data on carers previously that we want to compare to it later so that we have an idea of whether or not practice has changed over time. But for the purpose of today, we're just going to talk about the contemporary perspective. There was representation, like I said, from all states and territories. Predominantly, we had women who were participating. And compared with carers who did have biological children, those without biological children, that 33%, tended to be younger. They were 35 to 44 versus 45 to 54 for those who had biological children. And this makes sense. This demonstrates that those who are older had their children, raised their children before they became carers. And the average age of care in Australia is between 45 and 55. So I'm sitting right in that sweet pocket personally. Don't know about the rest of you. Those who had fewer years of fostering were in this younger group who had not had biological children of their own. But incidentally, they tended to be more educated than those who did. So just a few more details about them. The length of time that they had providing care varied, with the most prominent being 1 to 5 years, followed by 6 to 10 years. I'm in that 19% there, where I was 16 to 20 years currently, and my lights have just gone out. Sorry about that. And the number of infants that they had cared for. So we had a variety. We had some who had only cared for one, up to others who had cared for more than 60. So there was a lot of experience and a lot of range of experience in the sample that we talked to. So we asked questions regarding the arrival of the infant and found that the majority of infants were either transported to the carer's home by the caseworker, or the carer collected the infant from the hospital. More than half of the infants placed were less than 1 month, with 1/3 of the infants being less than a week when placed into care. So we are talking about extremely young infants moving into care. And as I said previously, when you have a caseworker transporting the infant, there's difficulty in terms of handover. When the carers go to the hospital to retrieve the infant, that's the best case scenario, because at least the healthcare professionals are able to communicate. However, not all infants go into care straight from hospital. Sometimes they go into care from home or daycare or things like that. So we asked carers to provide their understanding of why the infant had been placed into care, and the highest proportion of infants being placed into care was attributed to parental substance use or parental mental health issues, and sometimes the two coincide. A quick analysis of the other option, which you can see towards the bottom, revealed that some carers believed Infants who were pre-adoptive had been placed into care, and others felt that they had been taken into care based on parental history or the fact that their siblings were already there. Of those infants, of those carers who said parental substance use issues were the reason they understood the infant had been placed into care, 98% said it was likely that mom was using during pregnancy. Of course, they had no confirmation of this, but 98% said it was likely. Of those carers, only 20% had received any training related to caring for an infant who had experienced prenatal substance exposure. Only 20%. The majority of infants, or 38% of the infants, were in the hospital prior to entering into care. Among these, of those children arriving from the hospital, 80% of them were under 1 month of age. So again, just trying to paint a picture of what the infants are like when they're coming into care. So many coming from hospital, many of them at a very young age, and many of them due to parental substance use issues. So the survey also asked questions regarding the support, training, and information that carers were provided prior to and at the time of infant placement. Approximately 1/3 of the infants were visited by a community nurse or midwife in the carer's home, and 3/4 of the infants were taken for visits with community health nurses while in care. 1/3 of the carers, about 30%, reported receiving information or training related to infant feeding. We wanted to know about 8 different topics related to the care of infants in out-of-home care to see what kind of information and support and training was provided to carers prior to or at the time of the infant being placed into care. We also looked to see if responses differed between carers who had biological children versus those carers who had no prior parenting experience. And like I said, overall, just 1/3 of them received information related to infant feeding. So things like how to use a bottle, how to sterilize a bottle, how to select which teat, what bottle to use. And of those, that 30%, only 23% of them found this information themselves. So it was not provided by the hospital or an agency or foster care agency. 22% of carers without biological children received information compared to, 22% of carers with biological children received this training and information compared to 46 of those without biological children. So clearly they were able, those who had not had prior parenting experience were able to get information. Overall, just under 1/4 of the carers reported receiving information or training related to infant nutrition. And of those, 35% reported sourcing it themselves. This also differed between those with and without parenting experience. 20% of those with versus 30% of those without parenting experience received training on nutrition. Just over 1/5 of the carers reported receiving information or training related to infant immunization. And of these, 43% sourced the information themselves. And less than 1/5 of carers reported receiving information or training related to infant bathing, sleeping, and settling. And of these, around 30% found that information on their own. This differed, though, between those with and without prior parenting experience. 13% of carers with their own children received information and training on sleeping compared to 28% of those without children. And it's 9 versus 28 for bathing. Less than a 1/5 reported receiving information or training on developmental milestones, with 60% reporting they sourced this information on their own. This differed again between those with and without, 19% of those with and 32% of those without prior parenting experience. About 1/3 of all carers were provided with information on infant attachment or developmental trauma. 33% of these report sourcing that information on their own, and only 11% report sourcing information about developmental trauma themselves. And this did not differ between those with and without parenting experience. When the 8 categories are considered together, it was found that 41% of carers did not receive any information or training at all. Let me repeat that. 41% of carers did not receive any information or training related to infant care at all. 28% received training in 1 or 2 areas, and the remaining 31% received training in 3 or more areas. However, many report sourcing the information or training themselves. Carers indicated they had an overall high confidence level that they would be able to adequately care for the infants when they were placed with them. But despite this confidence, the great majority of respondents agree that training specific to infant care should be provided to carers, and that they themselves would have benefited from such training. Overwhelmingly, respondents indicated that infants in out-of-home care should receive in-home visits from nurses and attend community health clinics. And this did not differ whether they had prior parenting experience or not. I just want to change directions for just a moment and tell you about another paper that was written. We wrote a paper looking at the diagnosis of NAS, or neonatal. This is a syndrome that refers to the withdrawal period that children who experience exposure to opioids tend to experience. But increasingly, this term has been used for any child, at least in the Australian context, who has been born prenatally exposed to substances. Unfortunately, the diagnosis is not made unless the child is actually demonstrating withdrawal symptoms. In fact, there is no enduring diagnosis for a child who's been prenatally substance exposed. During the last 20 years, evolving knowledge shows that withdrawal is only the tip of the iceberg, and that some problems may take months or even years to manifest after being prenatally substance exposed. There's an Australian data linkage study that showed when compared to other children, 3,842 children with a history of prenatal substance exposure were 3 times more likely to die, usually from preventable causes, twice as likely to be hospitalized, twice as likely to fail in standardized curriculum-based tests, and 15 times more likely to have a major disability, 40 times more likely to be assaulted, maltreated, and injured. A cohort study showed that by age 5, 1 in 2 American children with a history of prenatal substance exposure has been diagnosed with a mental health disorder, the most important predictor of future adult mental health and early death. Prenatal substance exposure is a global health problem, and it doesn't resolve after withdrawal. So we wrote this article drawing attention to this fact. And in the article we state, attention needs to focus upon events after withdrawal, recognizing that prenatal substance use has consequences beyond the neonatal period and provides an enormous opportunity to support not only the infants, but their families and communities. We believe that there's an ethical obligation to recognize that there are enduring effects of prenatal substance exposure, and that we need to be able to provide support to children and their caregivers. This is really, really important because as we talk about infants and the need to support cares of infants, we need to understand that infants grow up and a lot of these problems can be persistent. Our most recent study, and you guys are getting the first glimpse, we looked at cares of prenatally substance exposed infants. We had a total of 88 participants, some from America and some from Australia. They were all women and most were employed, and the majority indicated they were modestly confident that they could provide care to these infants. At a scale of 1 to 10, they gave it a 6.5. Less than 0.5% of the children that we asked them about had no ongoing health issues, only less than 0.5%. The carers reported that 57% of the carers reported the child in their care who had been prenatally substance exposed had mobility problems. 80% had behavioral issues. 58% had learning difficulties. 40% had diagnosed mental health conditions. 38% had cognitive issues. 13% had hearing issues. 25% had vision issues. And 51% reported additional health-related issues. Only 21% of this cohort had ever received any training specific to caring for prenatally substance-exposed infants or children. A resounding 98% of this participants in this study indicated that more training should be available for carers. The services that they were receiving for their children, 19% were receiving psychological or psychiatric assistance, 6% had community nurse visits, 43% were seeing occupational therapists, 26% saw pediatricians, 11% had physiotherapy, 13% had speech pathology, and 15% attended support groups. Only 13% of the carers in this study felt that they received sufficient support for the child in their care, and 100% indicated there was a need for more services. 91% felt prenatal substance exposure would impact childhood and adolescence. 94% felt it would impact the child's adult life. This is the first study of its kind to actually seek information and opinion from those affected by NAS directly after the infant's been discharged from hospital. And the results demonstrate that there is a significant burden on foster carers in caring for these children, with burgeoning health issues, a lack of training, and overwhelming need for more support after the child outgrows infancy. Despite these foster carers coming from two countries with different healthcare systems, resources, and burden of physical and mental diagnoses, and support remained similar between the two samples, the outcome was the same. The results of this study align with what the research has been saying for a while. So clearly, current treatment options focus on biological families, particularly the mother. There's minimal recognition of the enduring impact of prenatal substance exposure. There's a need for more research and awareness. And there is no enduring diagnosis, but without one, children in Australia will not be able to receive services. This study, looking at infants, carers' experiences of looking after infants, providing, wanted to understand how best to support them. And the results indicate that overall carers are not well supported. And there were significant differences present in the training given around basic infant care, with carers who had no biological children of their own more likely to receive training than those who had prior parenting experience. Although more likely to receive training, this still only equated to 1 in 3 carers getting training. Information and training related to infant attachment and developmental trauma were most commonly offered to carers. And this reflects a growing understanding and acknowledgement of the importance of primary attachment for healthy infant development. And it also demonstrates an understanding that infants can and do experience trauma. Trauma can significantly interfere with a child's early development. It can disrupt attachment, delay language, impede social skills, and inhibit emotion regulation. And infants who experience trauma often fail to meet developmental milestones in a timely fashion. However, you need to know what those milestones are in order to recognize that the infant in your care is not meeting them. And our study showed many of these carers didn't know those. The results of this study indicate not all carers have access to this information, and the infants in their care may be at risk of inadvertently falling behind because of that. A positive attachment relationship with a primary caregiver is fundamental to healthy infant development, and this attachment is especially important for infants who have experienced trauma, but it may also be more difficult to develop, as some infants may withdraw, avoid eye contact, fail to give off cues, and regularly self-soothe, rather than seek out nurturing from their primary caregiver. Carers who have an understanding of this are more likely to engage proactively with infants in order to foster attachment. But if carers are not aware of this, infants can become increasingly disengaged and fail to develop along a typical trajectory. Our research demonstrates that some carers are receiving this information, but the vast majority of carers did not. The first days, weeks, and months of a child's life are critical period for healthy development, and in infants in out-of-home care are to achieve their best possible outcomes, carers need to be educated on how to promote the infant's health during this time. It is concerning that so few carers were provided with information or training on basic infant caregiving. This is particularly troublesome for those carers who have not had prior parenting experience. The majority of these carers would not have attended antenatal classes or had a period of time in the hospital under the guidance of a nurse or midwife who could provide instruction. This lack of training can greatly impact on a carer's well-being, causing anxiety and a sense of self-doubt. In an interview, one carer spoke through tears, revealing that she felt poorly supported as she described a caseworker handing her an infant, a nappy bag, and half a tin of formula on a Friday afternoon. Perhaps there is an assumption that carers who have had their own biological children already know what they're doing, as they've had infants before. However, the survey data indicates that those carers with their own biological children, averaging the age of 45 to 54, the average age of a birthing mother in Australia has risen over the past several years, but it's currently around 30 to 34. Thus, biological children of carers are likely to be 10 years or older, leaving a lengthy period of time between infant caregiving periods. The guidelines continue to change as well. For example, SIDS changes many times over the years. Or perhaps the carer breastfed her children and did not have experience bottle feeding. I interviewed one woman who was 59 years old, whose youngest biological child was 21. She described feeling extremely anxious when receiving the care of an infant due to the length of time it had been since she'd had her own children. It's clear that this basic infant caregiving is not routine training delivered by the out-of-home care system, and one may ask why. It may perhaps be that this is viewed as an issue which should be addressed by the healthcare system, which is not illogical. Nurse home visiting programs are designed to support both the infant and the parent, ensuring early identification and intervention for troublesome issues, enhancing attachment and bonding, and increasing safety in the home, improving parental self-efficacy. But unfortunately, this study found that only 1/3 of the infants and their carers received these visits. In fact, one carer said when I interviewed her that her daughter had, quote, fallen through the cracks, aptly stating the gap between the healthcare and social service systems. Why are these infants not routinely being seen by home visiting services? It is likely due to poor referral pathways, as it's generally the mother who is referred. So in conclusion, my recommendations based on the research that we've done, carers desire and are likely to benefit from basic caregiving training. We have developed this training and been rolling this training out through My Forever Family in New South Wales this year, and it has been widely appreciated by the carers who have received it. Training related to attachment and developmental trauma should be provided to all carers of infants, and it should be developmentally appropriate. Usually, this sort of training hits older children, not infancy. Training related to prenatal substance exposure should also be provided. We have developed this training and are able to provide it to carers. Nurse home visiting services should be made available to infants and carers in the out-of-home care system. And this is something that we have been trying at my research group to get started for a very long time, and eventually we will. And finally, further research should investigate specialized nurse home visiting services that have increased information about attachment, developmental trauma, and prenatal substance exposure. Thank you very much.
Thank you, Stacey, so much for that. There's a lot to take in there. That brings us to the Q&A section of this webinar. So we've been receiving your questions, and if you've got any more for Stacey, please do add them now to the question box in the GoTo panel. In the meantime, Stacey, I have a question for you. Is dealing with this, given that health is a state-run, predominantly a state-run enterprise, this particular issue, is this something that would be dealt with at the state level or more the local area health network level? Where does the fix lie? Who do we need to advocate to specifically?
Really interesting question, Kieran. Thanks for it. I think at this point, I'd be happy for anyone to listen and to advocate to anyone. I think that it should be rolled out across the state. I think state healthcare systems and territory healthcare systems should be paying attention. But if we can get at least a local health district on board to pay attention and to say, hey, let's try some of these ideas. You've got some evidence suggesting that they would be useful. Let's trial it here. That's the first step. If we can get a local health district on board, and so we can demonstrate that these services actually make a difference for both the care and the infant. It's not just about getting great outcomes for the infants, but there is a significant attrition of foster carers at the moment, more so than there has been in past decades. Retaining foster carers has always been an issue. But if we have nurse home visiting services in the home of the care, helping the carer to recognize these different things that I'm talking about, trauma in an infant, or giving strategies to help an infant who is traumatized to develop attachment, and helping them to understand how to soothe an infant when it's come back from a visit, and make smart decisions about whether or not it's safe to give express breast milk to an infant. They're going to feel more supported in the role that they have. They're going to feel more confident that they're making good decisions. And if carers are feeling supported and confident, we're not going to lose them. And we're going to get great outcomes for the children in their care.
And you said it was a breakdown in the referral pathways. So should it be the medical system ensuring that the social service system has this information, or should it be the social service system demanding this information?
So one of the things that we have been trying to do, and we're really struggling to get the funding to do it at the moment, is to try and investigate where it's going wrong. So we have anecdotal evidence that says one of the reasons it doesn't happen is because it's usually the mother who gets referred. Another reason that that carers might not be getting this service is because an infant is born in one local health district and then placed into a different local health district for care. And so there's, cross-system issues happening there. I've been told by most local health districts that those services can be available to carers, but carers need to be educated and given the information so that they can ring up the community nurses and midwives and say, hey, I've just had an infant placed with me. Can you please come and do a visit? They wouldn't be turned away, but carers don't know to do this. And of course, the nurses and midwives aren't always aware of when an infant's placed into care. And in terms of in terms of our nurse home visiting services for infancy, there's a range of services that are available. There are basic universal services that are given to families who are coping well, that are there just to monitor and make sure that mom's not having any additional needs and that nothing's gone wrong for infant in the first couple of months after birth. But there are intensive services that are available for families who are facing adversity. And I would argue that when an infant is placed into care that's been prenatally substance exposed, maybe experienced neglect, maybe there's been some generational trauma, I would consider that family now facing adversity, because that's a really big challenge to be able to address. So I think sustained nurse home visiting services in that context are warranted, not just the well baby checks that happen.
Well, hopefully with the federal government's review of the early years strategy, maybe there are so many things to consider, but maybe this will form a part of that, that connection between health and development and education that are so interconnected in those first 1,000 days. We do have a question. It was that they missed the name of the symptoms. What does the acronym NAS stand for?
Sorry, NAS stands for neonatal abstinence syndrome. Another term that's being used currently is neonatal opioid withdrawal syndrome. But both of those terms refer specifically to opioid exposure. There isn't actually a term that's recognized that covers all exposure to different drugs, and the way that the drugs impact on the infant differs. So in America, for example, NOWS, the neonatal opioid withdrawal syndrome, is a very common diagnosis because they have, at the moment, one infant born every 15 minutes that's addicted to opioids. They have a huge opioid crisis in the United States. Whereas when we look at the information that's available here in Australia, methamphetamine, ice, and ecstasy are much more common for infants to be born exposed to. And the way that those infants present is completely different. So infants born to opioids, exposed to opioids, are the infants that you would have seen documentaries on, where the infant's screaming and the infant is tremoring and the infant is having all sorts of physiological responses to the drugs leaving their system. Whereas the methamphetamine babies look perfect. They're quiet, they don't cry, they self-soothe. And the danger is, because they are such, quote, perfect babies, is that when they're placed into care, carers won't understand what's happened if they're not given the information. And because methamphetamine babies are so quiet and they do self-soothe, they don't look for nurturing. They don't cry to be held. They don't seek out opportunities to learn. And this is a real danger, because if you place an infant with a carer who might have a couple of children of their own and maybe a toddler in care as well, and the baby seems perfect, then yes, the carer will be able to tend to everyone's biological needs. But what's happening is the infant's mental health is suffering, because infants actually need to have eye contact. They need to be spoken to. They need to be held. They need to be stimulated. And usually in a typical developmentally, a child who's developing typically, they stimulate that by demanding our attention. They cry or they give off cues. Babies born exposed to methamphetamine don't do that. So they're at risk of being inadvertently neglected because we're not giving that information to carers.
That's really great information, actually. I have another question, but in the meantime, from the audience, we have a question he or she says, thanks, Stacey, for this interesting presentation. In your experience, how can the drug and alcohol services in local health districts support mothers and infants with the NAS condition?
That's a really good question. There are some specific services that are available to mothers and infants. They're not in all local health districts. For example, there's the Substance Use in Pregnancy and Parenting Service, which works with mothers who are pregnant and have substance use issues, and they follow them up and provide in-home follow-up for their infants and children, and that's really important. The research actually talks about the services that are most effective for women who are using substances. The services that are most effective are the services that allow mothers and infants to stay together. So the Four Corners episode that my son and I appeared in highlighted one of those services. And those services are really very beneficial. I was a bit disappointed, though, with that particular documentary, because they failed to talk about the infants that don't get that service. So for the mother that they profiled, the child in her care that she had managed to have with her in that service had 7 older siblings who had been placed into out-of-home care. That infant wouldn't have been given the same amount of support, and obviously the mother wasn't supported with that infant either. And what we really wanted to draw attention to was the fact that many of these infants end up languishing in hospital for a period of time during withdrawal while they wait for a foster care or a kinship care to be identified. And while we're leaving those infants without a primary caregiver, particularly when they're uncomfortable and in a noisy, strange place, we're actually doing damage to their neurologic development. And that's what I was hoping that they would highlight, but they failed to do so in that program. In terms of the drug and alcohol services, though, the best thing that we can do for mothers who are using is to support them with their infants, keep them together. We don't have enough services like that in Australia currently.
Great. Yeah, so if you haven't seen that Four Corners episode, I do encourage you to seek it out, because it was certainly an impressive service. I think it was in Melbourne, and there was a lady who was the first of her 8 children that she'd ever been able to keep with her. We have another question, and it does relate to what I was going to ask you about, which is FASD. The questioner says, I feel like we're on the verge of a diagnosis that would explain so many of our foster kids and be so helpful, such as the FASD diagnosis was. In comparison to the work being done there, is it comparable, or are we well behind, or are some of the same researchers doing the same work but on different sort of substance areas?
It sounds very strange to say this, but if a child has a diagnosis of fetal alcohol spectrum disorder, or FASD, it is a golden ticket in this country, because it means that they can access services from the NDIS. It's recognized. It gives them all of the supports that they need. Unfortunately, for a lot of children in out-of-home care, they cannot receive a genuine diagnosis, because part of the diagnostic process is an account from the mother regarding how much she drank during pregnancy. And this is often not something that we can access as carers. In Sydney, the #1 place to take children to have them assessed for this condition is the Cicada Clinic at Westmead, and it has a 2-year waiting list. And 2 years is a very long time in a very young life. But a FASD diagnosis is something that can help children to get the services and supports that they need. And many children who have been exposed to other substances have also been exposed to alcohol and received that diagnosis. In terms of these other substances, unfortunately, the research is really gray. It's not rigorous. There are so many different substances, and there are so many different periods during pregnancy where mothers can be using substances, that it's really difficult to be able to isolate something and say, if in the 3rd month mom uses methamphetamine, this is going to be the outcome. Because it might be that we never know that she used methamphetamine during the 3rd month. Or it might be that she used methamphetamine and smoked marijuana and was drinking alcohol. And it's really difficult. It's a very complex area to study. We know a lot from rodent studies, which sounds crazy because we don't want to equate our children with rats, but we do know a lot from rodent studies that demonstrate lots of outcomes that are likely to occur and that we see anecdotally. But in terms of cause and effect research, we just don't have it. We have correlation research, like some of the research that I cited to you in that related to children that study with 3,482 children that showed that they were more likely to experience violence, more likely to have behavioral problems, more likely to die early. Those are correlation studies saying that this is what their beginning was like and this is what happened during their life. But cause and effect is really difficult because ethically we can't just say, okay, let's get 10 women pregnant and give them this drug and 10 women pregnant, give them that drug, and then we'll see what happens. We can't do it. So unfortunately, the research is not where it should be, but more research needs to be done.
Thank you, Stacey. I don't see any other questions from the audience, and we're getting close to time now. So I think we should wrap up. So thank you to everyone who joined us today and who are watching the recording. The recording will be available in a few days' time on the RACE's website and on our YouTube channel. And also we'll share the links in the weekly RACE e-bulletin. And if you aren't already, you can subscribe to the e-bulletin with a link that's in our chat box currently. And also, Stacey, I was wondering, you referred to a couple of other studies in your session, not just the main one that we first talked about. And would you be able to share links to those as well? Could we share those with people? Great, thank you. So we'll include links to those as well, because there was a couple of others that sounded really interesting. So thank you once again, and thank you particularly to you, Stacey. We will continue to do the best we can to advocate for children in Australia at RACE. So we'll bring the event to a close, and we look forward to seeing you all at our next webinar.